Once the patient gets in the department, whether they're external beam patients or brachytherapy patients, we would place them onto the Zephyr table. We do the placement of those catheters on the Zephyr table, whether they're needles or GYN catheters. Then one of our techs will be able to move that patient into the CT for a CT acquisition. They're in that same position that we've placed the catheters in. They're in that same position. We do the CT acquisition in exactly the same position when we treat them. This is something that we do not accomplish or cannot accomplish without this type of technology. That consistency in being able to move the patient from one room to the other or one table to the other in that lithotomy position is very important to be able to provide that accuracy in dose distribution. We're currently finalizing our last study when it comes to how accurate is the actual movement of the patients and how much are the catheters moving as we're moving patient from one place to the other. We're currently in I believe it's 0.3 millimeters. So, being in less than half millimeters to upwards of 5 to 6 millimeters, if you were to physically move these patients back and forth, that's a 10-time accuracy improvement that we're seeing. And when it comes to brachytherapy, anything less or anything more than 1 millimeter causes huge sort of dose differences in these patients. So being able to reduce that movement in less than 1 millimeter has been a great improvement. At the end of the day, these patients are coming in for accurate treatment, so having these tools and providing that accurate treatment to them is quite important.